Is the screen visible?
Yes, sir.
Yes, sir.
Okay. So this is the 9 months old female child with peri-robin posted for cleft palate repair. And don't mention about the cleft with a gas roll and all those things in these cases. So
Okay,
it's
sir.
challenges to the anesthesiologist. This is an anticipated difficult airway, which is challenging to ventilate as well as intubate due to the dysmorphology in the patient. That is a small mandible, large tongue, and already existing airway obstruction. So maintaining a seal for ventilation using a face mask itself will be difficult in this case because of facial hypoplasia. Direct laryngoscopy and tracheal intubation tend to be very difficult during infancy. As the smaller the child, more difficult is this problem. But generally, as the child grows, the mandible also will grow, and then older children may not have that much of difficulty like the infants that you see. And a neonate with PRS may have increasingly sensitivity to opioids, so better to avoid any opioids in this case. And they may have OSA also because of glossoptosis during the time of their growing age from birth to up to say 9 months when you are going to operate. You must ask for history of OSA because of the large tongue obstructing the upper airway. So majority of the mothers will give you a history that I make the child sleep only in the prone position, otherwise she gets choked. So I will always put her on my lap in the face down position and pat her, and she will go off to sleep. And throughout the night, she is comfortable only in that position. So this history is very important. And they may have feeding difficulties, swallowing disorders, and coexisting gastroesophageal reflux also may be there in this patient, which can lead to microaspiration and pulmonary infections. So preoperatively, you have to make sure that there is no history suggestive of any repeated attacks of pneumonia or pulmonary infections because of aspiration. And patients generally are malnourished sometimes because they are not able to be fed properly and have a high frequency of failure to thrive due to difficulties with feeding and airway, and maybe the weight gain may not be adequate for the age. So that is another important thing which will be challenging to you. Coming to the pre-anesthetic assessment, you have to ask about the birth history, whether the patient was born at full term or is a premature baby. Why the history of prematurity is important? When you want to do a surgery in a premature baby, what is the important post-op complication you have to anticipate?
Apnea of prematurity, sir.
Apnea of prematurity, fantastic, very good. Is there any method to prevent that happening? Any drug that can be administered?
Caffeine, sir.
Caffeine.
What is the dose?
mg.
20
Ten
mg per
ml.
kg. Per kg.
Per
Okay, it
kg,
is not
sir.
just 20 mg, it is 20 mg per kg that can be given, which is available, can be given as oral as well as parenteral. And what is the post-op care that you have to take?
Supplement oxygen, sir.
Supplement oxygen. Monitor them. Prof apnea. Okay, one second. தகவலை கூப்பிட்டோமா கிளாஸ்ல இருக்கேன். Hello? Okay. So patients may go in for apnea and desaturate. That is the reason why they have to be monitored for the first 48 hours. That can happen anytime after 48 hours of surgery. So they have to be, even if it is daycare, you have to monitor them with a pulse oximeter all the time to avoid this complication. Then obtain history of patient symptoms, including recent URI, features suggestive of reflux, aspiration, all these things are important. And physical examination should make a thorough airway evaluation, and also cardiopulmonary examination and history of any OSA obstruction, how it is overcome. Of course, these children may not require CPAP or BiPAP, just a simple prone position, or sometimes surgeons to do what is called lip adhesion. They pull the tongue out and suture it to the lower jaw. That will way they open up the obstruction at the pharyngeal level, and that may also be one of the methods of getting over the OSA. And The other things is you must do the oxygen saturation measurement in room air to see whether they are already having any hypoxic episodes because of airway obstruction, and you should measure the heart rate, respiratory rate, and blood pressure of these patients. Now, preoperative investigations, it is just something like a routine one, CBC, electrolytes. In case of undernutrition, you have to do the electrolytes. Otherwise, you can do the routine renal functions, video laryngoscopy. In older children, of course, not in very small babies, chest X-ray and CT. Echocardiogram, if there is any murmur, indicative of congenital cardiac defects. Now, the challenges of airway management during anesthesia. This will be the main point of discussion in the exam. It is to maintain spontaneous ventilation, whether under sedation or general anesthesia. This is the most basic thing that you have to remember. Never paralyze these children. Upper airway obstruction is very common in PRS and relieved by two-handed jaw thrust by an assistant, or you can use adjuncts like oropharyngeal airway, nasopharyngeal airway, or laryngeal mask, or simple lingual traction. So these are all the methods of preventing the upper airway obstruction. And in cases of very severe airway obstruction and anticipated difficulty, it is always better to have a ENT surgeon who can do an emergency tracheostomy or bronchoscopy available by the side of the patient during induction. And techniques to secure the airway include laryngeal mask airway, fiber optic scope, and retrograde railing. Of course, this may be a little cumbersome in that. But direct laryngoscopy to intubate, you can use what is called right paraglossal approach, where you can avoid directly going through the oral cavity. You can go by what is called right paraglossal approach, which is more effective than the standard technique. And asleep fiber optic intubation, which breathing spontaneously is more safer, that you can achieve by inhalation of CO in oxygen. And for palate repair, oral ray tube is the tube of choice. And definitive treatment for this sometimes is lip adhesion. As I told you, pull the lip out and suture it to the lower jaw, or they do what is called mandibular distraction. In children who are not having a cleft palate, they may be brought for this particular procedure, what is called the mandibular distraction, to improve the size of the mandible by creating an osteotomy and then putting screws and rods and gradually expand the size by increasing the distance. And for that, you may need to do what is called a nasal intubation for this particular procedure. And anesthesia can be induced with sevoflurane and oxygen or intravenous propofol, preserving spontaneous breathing. Again, this point I am highlighting because it will be very disastrous if you paralyze the child and if you cannot ventilate the child also. Dexmedetomidine may preserve the respiratory drive, less incidence of apnea and respiratory depression and airway obstruction, that also has been used. And it is highly favorable for children and prone to have airway collapse and respiratory depression. These children are more prone for that. In short, half-life, the dexmedetomidine half-life makes it a preferred agent for ambulatory pediatric procedures, CT and MRI also. That is what I told you in the earlier discussion also. Once airway is secured, the rest of the management is like any other palate repair case. Okay, so the mouth gag will be applied and mouth will be opened, and then there will be a gauze pack around the tube near the larynx to prevent aspiration. And the dissection may involve little more amount of bleeding. So that can be avoided by infiltrating the mucous membrane of the palate with saline containing dilute adrenaline, or you can use tumescent fluid also. We used to infiltrate in our experience in Stanley Hospital, which gives both post-op analgesia as well as very good hemostatic feel. Okay, so all those things are routine. So I'm not going into those details. So the exam point of view, these are the three important things you have to remember: how to manage the airway, and lastly the post-op airway obstruction is also very common in these patients unless proper care is taken. So in our children who are having pre-existing airway obstruction or with history of obstructive sleep apnea, chronic hypoxia, don't give any opioids for them for pain relief. Use as far as possible paracetamol or local infiltration in the blocks, more safer. So prolonged surgical duration, pressure exerted on the base of the tongue by retractors and airway edema, these are the causes of post-op airway obstruction. And complications are minimized by performing neck extension and jaw thrust alone sometimes, or introduction of nasopharyngeal or oropharyngeal airways. But after palate repair, many of the plastic surgeons do not prefer introduction of any airway in that because they feel that the suture lines may get dehisced or affected. So, but some people who say that gentle introduction of these airways is not contraindicated. And nursing the child in lateral position with a neck extension can also reduce the airway obstruction. Non-opioid analgesics, regional blocks, and local infiltration can help in preventing airway obstruction. So this is the NYSORA flow chart that is given. Induction, spontaneous ventilation maintained. Inhalation with sevoflurane, intravenous to propofol. Laryngeal mask airway can be used for preventing the obstruction, not as the main airway securing for surgery. And if you can ventilate, maintain spontaneous ventilation, prepare to intubate by pleural colossal approach or medial laryngoscope or fiber optic through nose or LMA, depending upon the surgery. And maintenance with volatile opioid infusion, very short-acting opioid like fentanyl or remifentanil can be given, but not long-acting drugs. And alpha-2 agonist infusion like dexmedetomidine, and you can control the ventilation once the airway is secure. And during emergence, planned post-operative post-intubation, sedation to be continued in PICU. So this is the post-op management. But after induction by these methods, either inhalation or intravenous, if you cannot ventilate the patient, use oropharyngeal airway, two-handed jaw thrust. And if you are able to ventilate, and if it is a non-emergency, prepare to intubate by the same technique that you have, that either paraglossal videoscope or fiber optic. And in case it is not, you are not able to ventilate, one more attempt at laryngoscopy or emergent rigid bronchoscopy, LMA or tracheostomy. That is the ultimate thing that you have to remember. So these are all the things that we have to remember with regard to this thing. Any doubts on that?
Sorry, while placing FOB, we can start with dexmedetomidine, then we'll go for our like we are doing in adults.
Yeah, you can do dexmed and then you can spray the adequate local anesthetic block is necessary for FOB. You know, just like, whereas inhalation induction, you can even without spraying or without local anesthetic, can take the patient to the adequate depth and intubate without topical. On the contrary, with dexmedetomidine, it is mandatory that you always do the topical spray as you go technique and block the reflexes.
Yes, sir.
Okay, now it's 7:30. Shall we go for some Osce? If you don't have any doubts on this particular, I don't want to come back to the screen and then go back to this. Is it okay?
Yes, sir. Yes, sir.
Okay. Yes, sir.
Okay. Are you able to see this picture?
Yes, sir.
Okay. Identify this.
Normal distribution curves.
Normal distribution curve. Fantastic. Very good. This is a standard normal distribution curve in statistical analysis. Very good. What are the three salient features of this?
Mean, median, mode and are all equal.
What is the shape?
It's
Bell
bell-shaped.
shaped.
Bell-shaped
Bell
curve.
shape. It is symmetrical or asymmetrical?
Symmetrical.
So bell shape, normal distribution curve is always bell shape. Symmetrical, the normal distribution curve is symmetrical about the mean, meaning that half of the values fall below and fall above. The median, mean, and mode are all at the peak of the curve. So these are the three salient features of the normal distribution curve. What is standard deviation?
The deviation from the normal distribution curve.
From 97% of one standard and
Okay. The measure of how dispersed the data is in relation to the mean. Okay. So how far or close or away from the mean is what called the standard deviation. It's a measure of how dispersed the data, whether it is close to the mean or away from the mean. What is the symbol of this standard deviation?
sigmoid.
Sigma, not sigmoid. The sigma.
Sigma.
Sigmoid is colon. Sigma, S-I-G-M-A only. Okay. So low or small standard deviation indicates data are clustered tightly around the mean. And the high and large means standard deviation indicates data are more spread out. Okay. So these, you can see these are the two standard distribution curves which show this is you can see here the standard deviation will be very close to the mean. The center line is the mean. So it is clustered close to the mean, whereas in a large the gap is very high, but the height is reduced. Okay, so that is the low, small, and high, large. What is sample size and what is its importance?
Sample size is number of participants in a study.
Study. A small proportion of the population. The sample size is nothing but a small proportion, because supposing you want to do a study, you can't be going on questioning each and everyone in a particular place. There may be thousands, I mean lakhs and hundreds of people will be there, isn't it? So
Yes,
you take a small proportion, this is called the sample. So it is subpopulation to be studied to draw an inference from a reference population. That is the definition for sample size. Subpopulation to be studied to draw an inference from a reference population. And what is the importance of that?
Sir, higher the sample size, lesser will be the error, sir. So
very good. Larger the sample size, not say higher, it has to be said larger the sample size, lesser the chances of error or false positives, and smaller the sample size, more chances of error. Okay, large samples are more accurate, will be the study. Now, this question I prepared from the latest article or the essay that has come out in the World Federation of Society of Anesthesia. Tutorial of the week, the current one, which is published on the 5th of November. Okay. So
yes.
Last class, if you all remember, I showed some of the anti-diabetic medications used for treatment of obesity.
Yes, sir.
I showed you some multiple choice questions and asked you. That has come out as a full article this time on the WFSA ATP. So from that, I have prepared this question, hoping that examiners may also be aware of this article and start asking all these questions. So what are incretins and where are they produced?
They are
It's a
glucagon
hormone that
peptide hormones.
What hormone? Peptide. Yes, peptide
Peptide
hormone.
hormones.
And where are they produced?
From the gut.
In the gut, correct. Why hesitation? So the
Yes.
incretins are peptide hormones secreted under neural control by gastrointestinal tract lumen cells following nutrient intake. So as soon as you take your food, these hormones are immediately released from the cells that are lining the gastrointestinal tract. Name two incretins secreted and their actions.
GLP-1 and DPP-4 in
Very good. So GLP-1, that is glucagon-like peptide 1 and glucose-dependent insulinotropic polypeptide. Okay. So GIP and GLP-1.
Yes,
And they are implicated in glucose control and
obesity.
satiety. That is your feeling of satisfied after eating. That satiety is the main action by these two hormones. Which cells of the GI tract secrete these incretins? We found that it is a GI tract lumen cells which are doing that. But is there any specific cells that you know of producing these two hormones? Right. If you are not aware of that, there are two cells called ileocolonic cells, L cells, which produce GLP-1 and GAP secreted by duodenojejunal K cells. These are the two cells which produce that. How long after food intake the incretins are secreted and how they are inactivated?
Soon after food intake, they are secreted, sir.
How
It is
long?
long lasting, sir.
Specific time.
4 to 6 hours.
30 minutes.
15 to 30 minutes after ingestion of food, because the food first goes into the stomach. From there, it has to come into the duodenum and then small intestine. Then only it will be stimulated, isn't it? And as long as it is in the stomach, where it is being churned and then produced as a time, that is the time there is no purpose for this. So after 15 minutes of our eating only, the food starts going from the. That is why the gastroparesis patient, it stays for a longer time. Okay. Whereas normal activity, the food starts going into the small bowel within 15 to 30 minutes, and that is the time this will be secreted, and it is inactivated by dipeptidyl peptidase inhibitor. So this enzyme activity is prolonged by our drug, which we are giving nowadays for as a first line of drug for control of diabetes. Okay, dipeptidyl peptidase in DPP-4 antagonists. Drugs which prevent the breakdown of this gliptins that we use, sitagliptin,
Saxagliptin.
are all mainly by this action. So where are GLP-1 receptors present other than GI tract? What are its effects? Okay, the distributed throughout the body, including the GLP, cardiac, adipose, and neural tissues. Their effect is where these extra GIT receptors, they suppress neural appetite centers, decrease hepatic glucagon release, and delay gastric emptying, enhancing satiety. Okay, that is the mechanism by which it makes you happy after you eat. Okay, enough. I have eaten enough. That satiety feeling comes by preventing delaying gastric emptying. So this is a very important factor for our anesthesia, because we want the stomach to be empty during especially general anesthesia, but this drug is going to delay gastric emptying. We will see why that is here. So what are the ASA guidelines in the use of AOMS? Can anyone say what is the expansion of this AOMS? Just make a guess. I told you it can be used for obesity treatment in the last class. In the clue,
Anti-obesity medication.
medications, yes, it is anti-obesity medications, okay, or medicines, whatever way you want to call that. If a patient has active GI symptoms such as nausea, vomiting, retching, abdominal pain, or bloating, delay the elective procedure and discuss relevant risks with the surgeon and proceed of the patient. So this is the ASA guideline for this particular medications. If the patient has active GI symptoms because of this drug, causing nausea, vomiting, retching, abdominal pain, or bloating because of the delay in gastric emptying, then delay the elective procedure and discuss relevant risks with the surgeon. If the patient has appropriately withheld, you have to stop this drug before you take up the patient for surgery because of this particular reason. Then you can, it's not experiencing any GA symptoms, surgery can proceed. So two conditions, the patient should have stopped this drug at least for 24 hours, or even while taking this drug he is not feeling any of these symptoms. That means the gastroparesis is not very severe in this case, then you can proceed with the surgery. These are the guidelines. And if the patient is asymptomatic but has not withheld the drug appropriately, proceed as if the patient is not appropriately fasted or perform a gastric ultrasound. So treat them as full stomach patients. We have vomiting or any treat them as full stomach if they have not stopped the medications. Okay, that is the three guidelines that you have to remember with these drugs is, one is, if the patient is symptomatic, do not proceed. Two, if the patient is asymptomatic after taking the drug, and if he has stopped the drug, go ahead. And even if he has not stopped the drug, go ahead. But if he has not stopped the drug, and even though he is asymptomatic, you have to treat them as full stomach. And if ultrasound is negative for retained contents, or if it is positive or equivocal, then you have to take an appropriate decision and treat as though he is not properly fasted. So these are all the important considerations in this usage of drugs, which is becoming more popular in the treatment of obesity. So when obese patients come for either an incidental surgery or for corrective bariatric surgery, these are all the things you have to take into note when they are taking these drugs. And ASA could not comment on alteration in the current fasting guidelines for these patients. And what is the most important risk of these drugs and how can it be overcome? That is another question. So delay in gastric emptying is the most important risk, causing full stomach-like situation. So administration of prokinetic agent, especially intravenous erythromycin, 1 to 2 hours before anesthesia to accelerate gastric emptying. In this article, there is no mention about using our regular prokinetic metoclopramide. That has not been mentioned. They have mentioned only about IV erythromycin. Medication should be.
We are not able to see the
Screen,
slide, sir.
Yeah. Now?
Yes, sir.
Now it's okay, sir.
Okay, something happened. It stopped this. Okay. So medication should be withheld for at least 3 half-lives before surgery or procedure if significant clearance of drug is desired. Okay. Okay. So that is all about that newer drugs, GLP-1 and GIP, which I thought will be useful. Supposing they ask in the exam. What is erector spinae muscle? What is the other name for this muscle? Huh?
The muscle
You are
along
aware of
the
erector
spine.
spinae plain block. All of you should have studied, or some of you may be even doing it.
Paraspinal,
Spinal muscles.
paraspinal muscles.
It's not a single muscle, but a group of muscles and tendons which extend more or less the length of the spine on the left and right side from the sacrum or sacral region which to the base of the skull. So it runs through the entire back of the any person, and it is not a single muscle. So what is the other name?
So it does spinalis, longismus, and
No, those are
Leopold.
the 3 muscles which comprise this. But for the erector spinae, is there any other name? It's also sacrospinalis group of muscles. Okay, it's called sacrospinalis group of muscles. Name the muscles forming erector spinae and their disposition. That is the another. Of course, they, as you rightly started saying, there are 3 muscles. Iliocostalis, which is the most lateral. Then there is a muscle called longismus, which is in the intermediate column. Then there is a spinalis, which is the most medial. So all these three muscles are together they form the erector spinae. What is the target location to deposit drug in erector spinae plain block?
Between the transverse process and the erector spinae muscles, sir.
Fascia. Okay, right. It is most anterior and deepest layer of the erector spinae muscle and tip of the transverse process of the vertebra. Okay, it should be at the lateral most tip of the vertebral spine transverse process, not towards the vertebral body. What are the structures the needle has to pass through to reach this location?
The skin,
Main
subcutaneous,
muscles. Tell me the muscles which through which it has to go.
the trapezius, rhomboid, and erector spinae, sir.
Very good. So trapezius, rhomboids, and erector spinae. Very good. Mention indications for this block. Where do you use it?
Laparotomy is can use,
Laparotomy.
For breast surgeries,
Ribs.
Spinal surgeries.
thoracotomy is
It can be used as a regional anesthesia for a wide variety of surgical procedures on the anterior, posterior, and lateral thoracic and abdominal areas, as well as the management of acute and chronic pain syndromes. So, you need not, Osce, you need not write all individual surgical names. You can say surgical procedures done on anterior, posterior, lateral thoracic areas or abdominal areas, and for management of acute and chronic post-operative pains. What is the level at which this block is usually performed? Is it thoracic, lumbar, or
thoracic.
normally
thoracic
thoracic?
level.
T7. Okay, if the block is performed usually in T5 to T7 paraspinal levels, but sometimes it can be done at a lower level also. Because it is a continuous muscle, you can do it at a lower level, but ideally, usually done only in this level. What other bony structure is located near transverse process and how it is differentiated by ultrasound?
Ribs.
The ribs will be
Corresponding
there.
ribs.
Very good. Very close to the transverse process are the ribs in the thoracic region. And how do you differentiate it when you see it through ultrasound image?
So transverse process is a bit wider than the ribs.
Yes. Will be more superficial. Transverse process will be more superficial and wider, while rib will be deeper and thinner. Okay. What structures will be visualized if the US probe is too medial or lateral? What needle is preferred and why for doing this block? I'm supposed to keep the probe in what is called the parasagittal position and to identify the tip of the transverse process. Supposing it is close to midline, what will you see? If it is very much away from the midline, what will you see?
In the
Close
midline
to
spinous
we can see spinous process.
Sinus process. Before that, so to medial, you will see the lamina of the thoracic vertebra because the transverse process are attached to the lamina. From there only they are taking off on the right angle, isn't it? So they will see the lamina of thoracic vertebra, and if it is too lateral, you will see the rib itself because the rib will emerge from underneath the transverse process. It will come out. It is not the spinous process. You will see the spinous process means you are a dead midline. You are on the midline, so you should
Yes.
not go that much. Okay? Right. Rufi needle is the preferred to avoid injury to pleura and other vessels. So it is not done with the regular beveled 20-point needles. It is done with the Rufi needle to avoid the injury. Okay. What is strain of 4 monitoring? This is about neuromuscular junction. Some of the questions I picked up from the Osce that has been given in the last exam conducted recently, which results have come. All the students have passed. So I got the questions from Dr. Anjali Rajan. She
So
was
qualitative
amazingly
For
So neuromuscular
monitoring.
okay. It's a non-invasive method to assess the level of neuromuscular blockade and patient's recovery from the blockade also. So you can assess the degree or intensity of the neuromuscular block, and you can also use it for assessing the recovery from the block. Right?
Yes, sir.
How is TOF monitoring done? How do you do that? Of course, you don't say there is an option TOF button in the monitor and I just have to press it and we will get all that. Huh?
Will
So,
stim-
you need
Different.
central nerve monitors which are usually applied to the distal forearm to stimulate the ulnar nerve, and 4 consecutive supramaximal electrical stimuli, which are 2 hertz at a gap of 0.5 seconds, will evoke contractions or what is called twitches of the nectar pollicis of the thumb. So this is how the monitor electrodes are applied to the distal forearm to stimulate ulnar nerve. That is how the procedure is done. And you have to apply 4 consecutive supramaximal stimuli. The strength of that would be 2 hertz, and the gap between the stimuli is 0.5 seconds. They have asked the strength of the current, the duration, all in the last Osce. So that's why they've given all these details. What is TOF ratio and what is its significance?
Magnitude of T, fourth twitch by magnitude of T1, sir.
Okay. So it is the response of the fourth twitch to the first twitch. The ratio is T4 to T1 ratio is called the TOF ratio. What is the significance?
We can assess the intensity and recovery from the blockage.
Recovery, very good. NMB has to recover first before you extubate. It has to recover at least to 0.9. Earlier it was 0.7 was the value, but now they have made it that it should be 0.9 or greater to achieve safe extubation. Why and how PTC or post-tetanic count is done? What is the need for doing PTC and how it is done?
Post-tetanic count, we should give a more strength. It is painful, so we have to give 50 hits.
Why it is done? I will answer to why? When high doses of neuromuscular blocking agents are
Profound
given, the ulnar termination will show 0 thumb twitches. Okay, that is TOF will be equal to 0. To measure the degree of neuromuscular blockade in such conditions, when you have given a very heavy dose of neuromuscular blockade and TOF is 0, a tetanic stimulus of 50 Hz for 5 seconds is applied to the ulnar nerve, and the tetanic stimulus causes a large amount of acetylcholine to be released in the neuromuscular junction. This tetanic facilitation is subsequently followed by 15 single electrical stimuli delivered at 1 second intervals. And the number of measured thumb twitches make up the post-tetanic count. So this is how the whole thing will. And this will be telling about the intensity of the severity of the neuromuscular blockade when TOF is 0. Okay, so to find out how deeper or how intense the block is, for that only we use post-tetanic count. Now, how is the depth of NMB classified using TOF and PTC?
More than 0.9 is recovering and 0.4 to 0.9 is anesthesia. Less than 0.4.
How many PTC numbers or pitches you should get to say the intensity?
To,
Moderate,
for
it is classified into 3 categories.
Yes, sir.
Moderate, which
Moderate.
means TOF is 1 to 3 out of 4 pitches. Okay?
2,
And deep is 2, TOF is 0. That is after moderate, it becomes very deep neuromuscular blockade where TOF is 0, but PTC may have more than 0 twitches. It may have 1 or 2 like that. And intense neuromuscular blockade is both TOF and PTC or 0 twitches. Okay. So this is where in deep neuromuscular blockade, PTC helps to find out the depth or the intensity of deep blockade. So you may still have up to 6 twitches may happen, PTC. That means it is a deep. But if both TOF and PTC are 0, that is called the intensive neuromuscular blockade. Okay? So what is strain of 4 count? There was earlier post-tetanic count is there. There is another terminology called strain of 4 count. What is its significance and inference? Not heard of this terminology?
No, sir.
No. So counting the number of pitches is known as the train of 4 count. Okay. The train of 4 count indicates the degree of neuromuscular blockade. So train of 4 count, 1 means more than 95% receptor block. Train of 4, train of 4, 2 more than 85 to 90% block. Train of 4 more than 80 to 85. Train of 4 70 to 75. So this was the question that has been asked. If the TOF4 is not there, what is the percentage of blockade or value that has been asked? So this is what they say, the receptor blockade that is happening, various levels of this. So how does double burst stimulation help? Earlier we saw PTC is used for intense neuromuscular blockade when train of 4 is 0. Whereas double burst stimulation developed to detect even
Small
small
degrees of residual block.
Okay, even for small degrees of neuromuscular block can be identified by double burst stimulation. How is it performed? 2 short bursts of tetanus at 50 Hz at a supramaximal current are applied to the nerve. Okay, and each burst will have 3 impulses lasting 0.2 milliseconds. Each impulse is delivered every 20 milliseconds and the 2 bursts are separated by 750 milliseconds. So this is how the picture of you would have seen. So this is one double burst. So this particular rectangle has got 3 impulses in that of 50 Hz, which is the duration is 0.2. In between these two, you have a 20 millisecond gap like that. So there are 3 stimulations. Then there is a gap of 750 milliseconds between the first double burst and the second double burst. So this is the whole picture. And in what way DBS is superior to train of 4? Tactile evaluation of DBS ratio has been shown to be more accurate than tactile evaluation of train of 4. Because when you keep your hand on the thumb, you can feel DBS better than TOS ratio. Because even the small blockade can be detected. Why stimulation of peripheral nerve does not reflect the characteristics of the central muscles? Normally they say noting down the blockade at the ulnar level will not be equal to diaphragm or the pharyngeal muscles. Isn't it? All of you would have studied that. What is the reason for that? Because onset and offset of block is faster in central muscles with good blood supply. For example, muscles of diaphragm and larynx, they have a better blood supply, so their block onset as well as recovery much faster. Whereas peripheral muscles with relatively poor blood supply will have a slower onset of block and longer recovery time, like the adductor pulses, which we try to stimulate with the ulnar nerve stimulation. So the muscles of upper airway, pharynx behave like central muscles at the onset. However, they are sensitive to neuromuscular blocking drugs and recovery is slow, mirroring peripheral muscles. So this is one difference in the pharyngeal muscle. That is why you get that stridor and inability to keep the airway open, all these things in the pharyngeal muscle, because with regard to onset, they are as quick as the good blood supply muscles. Whereas for recovery, it is like the peripheral muscle, so it takes time, and that is why you get all the upper airway obstructions if reversal is not adequate, or the gap between the last dose administration and recovery is not having enough gap. What is tachycardia rhythm classification, and where do they originate? How do you classify tachycardias?
Sinus tachycardia, uh,
Narrow.
Narrow
supraventricular.
complex and broad complex. Okay,
Broad
divided
complex.
into two categories depending upon the width of the QRS complex. Okay, this is how it is classified. It can be wide complex tachycardia where QRS is greater than 0.12 millisecond, or narrow complex where it is less than 0.0. All narrow complex tachycardias are considered as supraventricular in origin, referred to as supraventricular arrhythmias, whereas wide complex tachycardias are treated as ventricular in origin, and they are more potentially life-threatening. What is important in the treatment of tachycardia, irrespective of whether they are narrow or wide morphology?
Maintenance of sinus rhythms.
Sinus rhythm.
Rate control.
Nice tonic.
Will you be able to feel a pulse when the patient is in this sort of tachycardia all the time?
No, sir.
Sometimes you may, sometimes you may not. Okay. So the treatment of all emergent tachycardia rhythms, whether narrow, complex, or wide complex, depends on the presence or absence of a pulse. Okay. Sometimes pulse may be present with a very fast rate or a slow rate. Sometimes pulse may not be present. Okay. So first and foremost thing you have to make sure is whether the patient has a palpable pulse or not. How does the treatment differ based on the presence or absence of the pulse?
If it's a
This
shock-
absence of pulse will give adrenaline. So
shockable.
Shockable.
If it's
Yeah,
pulseless electrical
Follow-
activity, will
Yes, you have some amount, some ideas, but concepts are not clearly understood. Okay, pulseless rhythms are treated under ACL cardiac arrest algorithm. Okay, whenever you are not able to feel a pulse, but the ECG shows a tachycardia, you have to treat it as cardiac arrest algorithm. The wide complex tachycardia would be considered pulseless ventricular tachycardia, which is treated in the same way as ventricular fibrillation under ventricular fibrillation algorithm. Whereas a narrow complex tachycardia, which also does not have a pulse, to be treated as pulseless SVT and treated under pulseless electrical activity algorithm. This is the guideline that we have to follow. In the presence of pulse, the specific treatment for all tachycardias depends on whether the patient is hemodynamically stable or unstable. So you divide the patients into two categories: pulseless patients with a tachycardia, patients with pulse having a tachycardia. So if they have a pulse, that means next thing is to check whether they're hemodynamically stable or you don't have any recordable BP or anything. And then start treating. In stable patients, it is usually medications to control their tachycardia, either in the form of amiodarone, diltiazem, or beta blockers. Like that, you can decide only. Usually, oral medications or parenteral medications will be sufficient. But if the patient has an unstable hemodynamics, then electrical conversion to sinus rhythm is required. Okay? So these are all the things that we have to. This is from the ACLS manual that is being given. So please remember all these points. Nowadays they are insisting more on ACLS management. So what is recommended energy level for synchronized cardiovation? How it is administered?
it's a elective procedure. We should start from 2 joules, sir. 2 joule per kg, 120 joule minimum. Low energy only we have to start it, sir.
For cardioversion, because it is synchronized with the
R waves.
Mild sedation we should give, sir.
URS complex.
So the recommended energy level range is from 500 to 200 joules, 50 to 200 joules. Okay? And the initial recommended synchronized cardioversion voltage doses are as follows. For narrow regular complex tachycardia like HVT and atrial fibrillation, 50 to 100 joules. For narrow irregular like monophasic atrial fibrillation, to 120 to 200. Then wide regular monomorphic ventricular tachycardia, you use 100 joules. Wide irregular, it means polymorphic ventricular tachycardia, then it becomes a defibrillation dose, and that is not a synchronized thing. What is the recommended treatment for stable tachycardia? It is patient as having a pulse and the blood pressure is recordable, but the heart rate is very fast.
We can give adenosine beta blockers.
Beta blockers.
Carotid
Stable,
massage.
narrow complex, you can try first vagal maneuvers. Okay,
Mm.
then you can give adenosine if regular beat is there. You can give beta blocker, calcium channel blocker, and also get an expert opinion on that. The patient is stable with a wide regular monomorphic tachycardia. You can try adenosine, consider antiarrhythmic infusion like amiodarone, and get an expert opinion.
Left side.
Identify the condition displayed in this.
Unilateral cleft lips.
Which side?
Left side.
Left sided wide. Not only left side, it's also bilateral. I'm not saying
Bilateral.
it's a bilateral complete cleft of lip and palate here. And see, this central portion is separate. There is a gap on the right side also. Okay? This is what you said. This is what is this condition and why it is a challenge to anesthetist. This is where Madam Shivasankari said about keeping a glass roll. Okay, this is only for this case. You can see the mandible is normal here. So this is a normal mandible child with a wide cleft on the left side of the nose and in the upper lip and the alveolus where your blade will be caught. So the case of wide left-sided complete left cleft of lip and palate, the cause of difficulty during intubation because the flange of the laryngoscope will go into the cleft and prevent adequate mouth opening. This can be overcome by placing a gauze roll on the cleft or using what is called the operator, which is used for feeding the children. Okay? There is a plastic thing which will be made, custom made for the gap, to fill up the gap while feeding to prevent nasal regurgitation. That is called operator. That can be kept in position. If the mother is using that, you can use that before you give the child later. Now this is our
Pierre Robin.
Pierre Robinson syndrome.
What is the
Low-set
triad
is small.
associated with this?
Microanthia, low set tears.
Glossoptosis.
Those ears are not a very important thing.
Glossoptosis.
Upper airway obstruction. Okay. What is the reason for the difficulty in intubation in this case? Already we are told the small mandible reduces the sparse of mandibular space. This is what you have to remember, causing inability to accommodate the soft tissues while pushing them with the laryngoscope blade. That is the tongue and other soft tissues. What are the techniques to achieve intubation in these cases? Just now we discussed inhalation induction, preserving spontaneous ventilation and intubation under deep plane of anesthesia. Inhalation induction and fiber optic intubation. Elective tracheostomy under LA and the inhalation or inhalation induction. These are the three options here. What is shown here?
Laryngoscopy blade.
Blade of
Laryngoscopy blade. Any specific name or any?
Macintosh.
Macintosh.
Laryngoscopic blade.
You are using Macintosh every day. Is it like that?
No, sir.
Looks so
Miller.
thick here. Is it like your regular Macintosh?
No, sir.
So this is called Bletchman laryngoscopic blade, a modification of Macintosh blade. Okay. So I'll just, what is the modification done and how does it help?
The front is straight, sir. It helps to lift the epiglottis.
And there is the light source.
What is this portion called? What is this?
Flange.
Flange.
Is the flange coming up to the tip like Macintosh? So the removal of the flange material near the proximal portion of the blade helps to sweep the tongue left tip of the blade upward and enhance view from the right side. Okay? So this is your regular Macintosh blade.
Macintosh.
You have been saying. You can see the difference between the two. Okay, I have specifically put this picture also so that you can appreciate the difference. Right? Now, what is shown here?
Narrow oropharyngeal axis.
Arrow?
Oropharyngeal axis.
What about the mandible?
So it is yes, sir.
Retrognathia reduced mandible or
The
space.
retrognathia CT. So CT of a head and neck showing narrow oropharyngeal area and short mandible with relative enlargement of the tongue. Okay, so tongue is big, mandible is very small, and there is a section in the
large tongue.
So how to intubate the trachea in these cases? Already we have seen awake fiber optic intubation is the method of choice with the older person. How to overcome the difficulties of fiber optic intubation? Was again jaw thrust and lingual traction, which we have already seen. Okay. How to break the bad news to relatives? This is another question.
Spikes protocol.
Spikes
Spikes
protocol.
protocol. Very good. What are the things in spike?
Yes,
Spikes is an effective way to breaking the bad news. So first thing is appropriate setting.
setting. Yes, sir.
This setting should have comfortable, quiet, private room. Should not be very congested. Make sure that tissues are available, especially when ladies are there, they will start crying and they will have to blow their nose out. So you must have adequate tissues. Ensure both you and the patient relative are properly seated. Ensure you have uninterrupted time during the meeting. Turn off all the papers, your cell phone should not all be working at the time. Other people who may be helpful can be permitted in the room. Ask the patient if they want anyone to be with them to first see whether they want some support. The second thing is perception. What are the things to be seen in perception?
What the patient already knows.
And begin discussing the sequence of events leading to the point of breaking the bad news. Ask about any symptoms the patient may have been experiencing up to this point. This is not only telling about any mortality, it's about morbidity also. That is also included in breaking the bad news. So don't imagine that we are always going to tell that the patient is dead. It can be a revealing a cancer in a patient who has not experienced or thought about it earlier. After laparotomy, you say that it is an inoperable condition. Those things, but also bad news. Okay?
Yes.
So what patient already knows or expecting is the perception. Then invitation. Check whether the patient wants to receive the results today itself. Then knowledge. Ensure you deliver the information in small chunks, sizable chunks. Don't go on endlessly talking all what you want to say in continuous way. Give a break, morning shot to any unfortunate news, and give a large gap between the session so that the patient can digest what you have told, and make it a very simple expression. Don't use bombarded medical jargons to explain the thing, and use the correct language. Pass between each piece of information and wait for the patient to reinitiate the conversation. And make sure your tone is respectful, slow, and clear to the patient. and give patient time to have their emotions and expressions to be done. Then comes the emotions and empathy. Recognize and respond to emotion, acceptance, empathy, and concern. Do not lie when the patient asks questions about prognosis. And consider asking about religious preferences to the patient. Then strategy and summary. Make a plan together and inform them what the next steps are. Reassure the patient and inform them the follow-up arrangements. Try not to rush the patient to make decisions, and check the patient's understanding of the bad news, and summarize respectfully and gently. Ensure to answer any questions the patient wants to have. Offer ongoing assistance to the patient. Offer assistance to tell other family members also about the bad news. Highlight where the patient can go and get more information or any support. And offer written materials if relevant and available, like brochures or pamphlets, whatever you have, you can do that. They're all the things. One more thing, we'll stop here. 40-year-old man with a body mass index of 41 kg per meter square, admitted to intensive care for acute hypoxic respiratory failure secondary to pneumococcal pneumonia. ICU day 2, ventilator settings are fraction of FiO2 is 0.8, PEEP is about 15, tidal volume 6 ml per kg. Patient is on amiodarone drip for atrial fibrillation. Ideal body weight calculated is 68 kgs. Vital signs are heart rate of 98, respiratory rate 30, blood pressure 130. The patient is arousable, follows commands. The abdomen is tend to palpitation and the tender, no tenderness. PaO2 is 80 mm. Abdominal pressure monitoring comments with the polymanometry. An esophageal manometric catheter is also placed. The balloon is in the intracardiac mid-thoracic esophagus. The decision made to proceed with progressive ventilation withdrawal in this patient. They want to remove the mechanical ventilation. Which of the following explain the best way to withdraw mechanical ventilation progressively from this patient? First option is first spontaneous breathing trial after 72 hours. Polymanometry guided PEEP regulation. Daily spontaneous breathing trial with FiO2 and PEEP weaning. Esophageal balloon guided PEEP weaning.
Esophageal balloon guided.
Daily spontaneous breathing trial with FiO2 and PEEP weaning.
So the correct answer is 3. Daily spontaneous breathing trial with FiO2 and PEEP weaning. Okay. What are the steps of spontaneous breathing trial? Who are exempted from reduction of PEEP during weaning?
Spontaneous breathing trial, we use TPs or pressure supports to wean the patient from ventilator. Patient who are hemodynamically unstable, we don't do spontaneous breathing trials. And who already had a failed breathing trial.
Now, the steps means what are all the things that we have to follow when you want to start trying the spontaneous breathing trial. And which patients are exempted from reducing the PEEP? Like what do you do with the tidal volume? What do you do with the peak flow rate and the airway pressure? What do you do with the respiratory rate? Like that. That is what is called the steps of SPT. Okay.
Okay,
so the duration lasting from 30 to 120 minutes. Weaning pressure support, PEEP and FiO2 to less than 50%. That is the first thing. Higher PEEP values may be acceptable only in patients who are having morbid obesity. Okay? So it is a gradual reduction in pressure support, PEEP and FiO2. That's what you have to say. Not about other things. How much alteration in. What 2 parameters are commonly used during deciding weaning from mechanical ventilation?
Adequate tidal volumes.
FaO2.
FaO2.
PaO to FaO2 ratio, okay, and rapid shallow breathing index are the two parameters which can be used independently or in combination to assess VC. Okay, PaO2 to FaO2 ratio and rapid shallow breathing index. How do you calculate rapid shallow breathing index?
Respiratory rate by tidal
Respiratory
volume.
rate by tidal volume.
Huh?
Tidal volume.
Respiratory rate by
Respiratory
tidal
rate
volume.
One at a time. So many I am not able to clearly.
Respiratory
Okay.
rate by tidal volume.
Between the two above parameters, which predicts success of weaning?
RSBI. sir.
RSBI, yes, RSBI predicts weanings better than PaO2, FaO2. How is RSBI calculated? That is the respiratory rate divided by tidal. How does esophageal manometry help in weaning? Okay, that is a surrogate for pleural pressure and can be used to optimize sleep in hypoxic patients with obesity. Okay, that is how it is speaking. What is intra-abdominal pressure? What is the normal value of IAP? And what are the effects of elevated IAP? What is IAH by ACS?
Should be less than 21 mmHg is a normal value. Effects of elevated IAP, it might it will decreases the FRC, sir, and the venous return is reduced. So decrease in cardiac output.
Okay, good. Right. So IAP is the pressure within the abdominal cavity. A normal IAP is only 5 to 7 millimeters mercury, but it can be higher in obese patients, okay, because of the fat compression. Elevated IAP can lead to organ failure, morbidity, and mortality. IAH, intra-abdominal hypertension, is defined as a sustained intra-abdominal pressure of more than 12 millimeters of mercury, while abdominal compartment syndrome is like acute coronary syndrome. This is also called ACS. Abdominal compartment syndrome is defined as a sustained intra-abdominal pressure of more than 20. So if you say volume of 20 millimeters, it is a acute compartmental syndrome, not normal. So normal is only 5 to 7 millimeters of mercury. So how to measure IAP? What criteria to be fulfilled while measuring IAP? Right. IAP can be measured by direct methods using pressure transducer or intraperitoneal catheter. That is why the earlier I showed you Foley catheter as introduced for measurement of IAP, and these are invasive. Okay? And the patient should be supine with no abdominal muscle activity, and the measurement should be taken at end expiration. That is the time that you measure the IAP. Okay?
Yes, sir.
Want one or two more or stop here?
Stop.
Yes. Yes.
Huh? Okay. So there are a lot more to see. Very clear. So I'll just stop here. And so you have no other questions? Kamachi, are you there?
Yes, sir.
Right. Shall we sign off?
Yes, sir.
Thank you.
Thank you, sir.
Thank you very much.